A very good afternoon to one and all of you. At the outset, let me thank the Mini Congress of the College of Ophthalmologists of Sri Lanka and Dr. Kusum Ratnaike for having invited me to give this talk on keratoprosthesis and overview. It also gives me pleasure to introduce my new center, code Iyer at Chennai, India, which will primarily deal with cornea, ocular surface, and dry eye related conditions. I have nil financial interests to declare, and pictures and videos are of patients I have had the privilege of treating in my earlier tenure at SN. So, I'm here to talk about keratoprosthesis and give an overview regarding the same. And keratoprosthesis, as we all know, basically means artificial cornea. Prosthetic corneas or KPROs form the last resort for bilateral corneal blindness, especially in eyes with end stage ocular surface disorders and in those which are at a high risk for conventional penetrating keratoplasty. Whenever we talk about KPROs, for the ease of understanding, it is easy to compare a keratoprosthesis to an intraocular lens. The parts of a keratoprosthesis are likened similarly to an IOL into a visual optic and the support system. The visual optic across all KPROs is made of polymethyl methacrylate, and the support system is further categorized into a haptic and a covering tissue. The haptic is basically what forms the skirt of the keratoprosthesis, and the covering tissue protects the entire KPRO. So based on your support system and the visual optic, we have different types of keratoprosthesis. In the type 1 KPRO, the support system is formed only by the haptic, which is the corneal carrier graft and the backplate. So this is how a type 1 keratoprosthesis looks, the Boston keratoprosthesis, and it is basically made up of three parts, and this is the final appearance of the K-Pro in the eye. Similarly, when we talk about the type 2 K-Pros, they are categorized based on the support system and which includes the haptic as well as the covering tissue. When you refer to the osteoodontokeratoprosthesis, the haptic is the tooth and the covering tissue is the oral mucosa. In the Boston type 2, it is the corneal carrier graft and the eyelid skin. In the osteokeratoprosthesis, it is the bone and the oral mucosa. And earlier on in the Pintucci keratoprosthesis, it was the Dacron mesh and covered by the oral mucosa. So this basically is the final appearance of the eye in these different types of procedures, and this is how it compares with a type 1 keratoprosthesis, with this being the final appearance of the eye following each type of K-Pro in C2. The indications, techniques, and complications of the various types of keratoprosthesis are very distinct. Broadly, we categorize them into type 1 and type 2. In the type 1, we have the Boston type 1, and in addition, the orokeratoprosthesis, which is an indigenous K-Pro. All the others fall under the type 2 K-Pros, of which the most commonly performed are the MOOKP, the Boston type 2, the Temprano keratoprosthesis, which primarily uses the bone. Now, how exactly do you choose a keratoprosthesis? This is one of the most frequently asked questions. And what we need to understand is the indications for a Boston type 1 are very, very different from the indications for any type 2 keratoprosthesis. So let's focus on the type 1 keratoprosthesis to begin with. For implanting a Boston type 1 keratoprosthesis in the eye, you need the eye to be moist, you need the eye to have a good blink mechanism, no exposure, and preferably there should be no underlying immunological condition, which is the reason we do not recommend doing a Boston type 1 K-Pro in an eye that has Stevens-Johnson syndrome or ocular cicatricial pemphigoid. As far as the type 1 K-Pros are concerned, there is a very distinct hierarchy of prognostic categories. The indications that have a very good prognosis include multiple failed grafts, viral keratitis, aniridia, limbal stem cell deficiency, and oil-filled eyes. The guarded prognosis includes the patients who have had chemical injuries, because these eyes are prone to developing uh, corneal melts, And of course, you have the pediatric K-pros. In fact, pediatric K-pro is a very controversial topic, and we do not, amongst the K-pro fraternity, really recommend doing a pediatric keratoprosthesis these days because of the various issues that are associated with K-pros in children. The poor prognosis, of course, like I mentioned already, are eyes with an underlying autoimmune condition, and usually type 1 is not indicated for these eyes. So basically, type 1 K-Pro is recommended for patients who suffer from end-stage bilateral corneal conditions and for end-stage bilateral ocular surface diseases which are moist and have no underlying immunological diseases. Moving on to the type 2 keratoprosthesis, how do you really choose which one of the various type 2 K-pros do you implant in a patient? Here, the indication would be an end-stage bilateral ocular surface disorder, patients who have an underlying immunological condition like SGS or OCP, those with severe dry eye, keratinized surfaces, severe chemical injuries with phoneal shortening and lid deformities. Of all the type 2 K-pros that are currently available, the first choice continues to still be the modified osteoodontokeratoprosthesis, which is considered as the gold standard against which the outcomes of the other K-pros are compared, followed by the Boston type 2 and the osteokeratoprosthesis. The surgical technique, as we all know, for the OKP is quite demanding. It is spread over a period of 6 to 9 months in three stages, and the eye is prepared to receive the lamina, which is nothing but the optical cylinder which is carried by the patient's own canine tooth. It is the root of the tooth which is fashioned into a lamina, and this is what is implanted into a subcutaneous pouch where it develops its fibrovascular covering, which is then implanted under the buccal mucosa into the eye, and the patient sees through the PMMA optic. Unlike the OKP, which takes 6 to 9 months over three stages, the Boston type 2 keratoprosthesis is a relatively straightforward procedure, that is a single stage procedure, and is usually combined with a total pars plana vitrectomy and an Amenth glaucoma valve in anticipation of retinal complications and raised pressure postoperatively. So the decision making, especially when you do not have a tooth, is something that we had described in this paper, which clearly delineates how you would go about taking a decision about the type of keratoprosthesis that you would choose and implant in patients who have very severe end-stage ocular surface disorders. Decision making, of course, depends on several factors. Most importantly, factors that are patient related with respect to the eye, with respect to the systemic features, whether the patient is fit for anesthesia or not, whether the mouth opening is good or not, and most importantly, willingness for compliance with follow ups, realistic expectations, and the socioeconomic status of the patient, which determines how frequently the patient will come back to you for follow up. And will be compliant with respect to using medications that are required in the postoperative period. Surgeon related factors also have a very huge role to play, and it depends on the kind of training that you have had, the kind of setup that you have, the ease of availability of anesthetists for general anesthesia, and your training with respect to the different types of keratoprosthesis. As far as the follow-up protocol is concerned, each keratoprosthesis has a different protocol, and the follow-up protocols are usually very stringent for these patients. For a type 1 keratoprosthesis, it's a mandatory 3 monthly follow-up. The bandage contact lens which is placed over the keratoprosthesis needs to be changed at each follow-up, and the patient is continued on topical antibiotics, a single day dosing of topical steroids and lubricants indefinitely. Whereas for the osteoodontokeratoprosthesis, it of course involves a slightly more lenient follow-up protocol where you need to ensure that the health of the keratoprosthesis and the mucosa is stable. For both these capros, you of course have to monitor the status of the optic disc. It's only the finger tension that tells us what the intraocular pressure is, and similar to the OKP, and the Boston type 2 keratoprosthesis, however, requires a much more stringent follow-up, very similar to a type 1 keratoprosthesis. What we all know about any type of keratoprosthesis is that it is definitely wrought with several complications, which is the reason why it is considered as one of the last resorts for end-stage ocular surface diseases. And complications are usually considered as the norm rather than an exception for these eyes. Usually, we tend to categorize complications following keratoprosthesis into ocular complications and the keratoprosthesis related complications. Ocular complications are those that we are usually used to seeing even with a penetrating keratoplasty at times, retinal detachment. You can have glaucoma, endophthalmitis. Well, in addition, here we do have a very high risk of RPM formation, sterile vitritis, and the capro related are complications which affect the covering mucosa or the skin. Most importantly, it is the periprosthetic tissue melt that is the most concerning when we're dealing with the keratoprosthesis, which could either be a melt of the corneal graft, it could be a resorption of the tooth or the bone, which compromises the stability of the keratoprosthesis, leading to a leak, leading to an extrusion of the keratoprosthesis, and this is one of the most vision threatening complications, second only to endophthalmitis in these eyes. So this is an example of perioptic melt in the different types of keratoprosthesis. That can present, like I mentioned, with a leak or an extrusion of the capro. Endophthalmitis is something that we are concerned about in any keratoprosthesis, and it could either be a fungal endophthalmitis or a bacterial endophthalmitis. The mucosa-related complications, have to be addressed in these eyes, and usually the outcomes are quite encouraging, and the mucosal complications can be addressed and treated. This was a hallmark publication of ours in the Indian Journal of Ophthalmology, where we described the current global scenario and a broad Indian perspective of keratoprosthesis across the different types of capros. And this was a meta-analysis that we published regarding the modified osteoodontokeratoprosthesis and describing the technique as well as its outcomes across published literature. Well, there was a lot that we have learned with respect to K-Pro's novel concepts that we have been able to implement in terms of bone augmentation, in terms of K-Pro exchange, the use of bone morphogenic protein to regenerate the bone in situ. Newer techniques like the Lux keratoprosthesis, which basically has a titanium sleeve around the PMMA optic, which improves the biocompatibility. However, this is yet to be FDA approved and freely available. We ourselves have modified some of the approaches to a Boston type 2 keratoprosthesis. Instead of doing it transpalpebral through the skin, we have done these procedures through the mucosa, and in fact now we do it even transconjunctivally or transclerally, through a scleral patch graft. So keratoprosthesis surgeries are basically about tailoring the keratoprosthesis to every patient, and understanding the nuances of the surgery, which helps us to tailor these artificial corneal implants based on the need of every patient. Well, there is still a lot that one requires to do in this field with respect to better IOP measuring systems, synthetic OKPs, biosynthetic K-pros, and improved designs of K-pros. And to summarize, what we need to remember and understand about K-pros is that this is the last resort for end-stage ocular surface diseases. These are meticulous and time-consuming procedures that require lifelong follow-ups. One needs to have a very high amount of passion and commitment towards the subject as well as towards these patients. It's a multidisciplinary approach wherein the anatomical and functional outcomes are very encouraging. As important as it is to choose a patient for keratoprosthesis, one needs to keep in mind that you need to be aware and trained in all the different types of K-pros and choose the right keratoprosthesis for a patient. It definitely helps to transform lives of patients who have been subjected to blindness because of either chemical injuries or Stevens-Johnson syndrome or any of the other end-stage ocular surface disorders. This is just a panel of photographs depicting the various types of keratoprosthesis and the good long-term outcomes in these eyes. With that, I would like to thank you for a very patient hearing and invite you all to the Institute of Excellence for Cornea, Ocular Surface and Dry Eye in Chennai, that both Dr. Bhaskar Srinivasan and myself have recently initiated called the Code Eye Care. With that, I would like to once again thank you all for a very patient hearing.